Well, thank you so much for y'all's time and the opportunity to talk with you. I'm new into town, so I got here and started in November. And I work with the Bunkie Clinic, which is based in the Bay Area. And they're sort of a group that focuses on microsurgical reconstruction of extremities, but kind of everything. If you have like a problem that's kind of a niche that not a lot of people treat, usually the Bunkie Clinic will take it on. And that's something that was attractive to me kind of looking for a job. So they offered me a new sort of spot in their clinic that they were expanding for in Northern California. And they wanted to have a presence around the kind of Roseville, Sacramento area. And that's why I'm here. So I had a presentation to go through. And I definitely find that y'all record it. All the patients here are from when I was working at the center in Hopkins, and they've all given their consent to sort of be on presentations and everything. But I do just request they kind of not share with outside of the group, since there are some patient faces on there. But they've all given their consent, and they know that these are part of presentations that are given. So I can go ahead and share the screen. Can everyone see that okay? Awesome. So, like I said, this is my group I work for. It's the Bunkie Clinic. We're kind of setting up shop so I'm basically operating and have privileges in Sutter Roseville. And my clinic space is sort of an ever-changing evolution, but right now it's in the trauma clinic. I help see some patients in the Sutter Rehabilitation Institute. So I'm also trying to go over to the PMR and physical therapy centers to kind of see patients that have spinal cord injuries and spasticity. And so I'm kind of all over the place and popping around. I don't quite have a home base yet, but that's a work in progress. Harder to get a clinic space than you'd think, but that's definitely coming. So I just want to introduce myself. This is my wife, Jenny. She's a critical care anesthesiologist. We both love outdoors and hiking and skiing and all sorts of stuff that you can't really do in Texas or in Baltimore. So I was kind of pining to get a job out on the West Coast for a while. And so the Bunkie guys offered me this one and I jumped on it. Then I learned that there was a the SRI, et cetera, is sort of this huge catchment area of patients that have different rehabilitation needs, spinal cord injuries, tetraplegia, but also spasticity and stroke. And it's sort of this kind of hub, which is very exciting to me because that's something I'm pretty passionate about treating. So I got into this, like I said, recently with only the last 2 or 3 years. And so I'm definitely new to it, but have done a lot of these surgeries out of Hopkins and Dallas before I left there as well. And it caught my eye because it's an issue that, like you said, Charlene, is sort of way underappreciated and way underutilized in terms of people offering surgery for it. So you may have seen this figure before, but at least for upper extremity tetraplegic patients, high spinal cord injuries, more than half of patients are probably candidates for some sort of surgical intervention or help. And they think that less than 5% get that. And that obviously depends on where you are, but this is even in major cities. San Francisco has a couple centers doing this. Stanford's one of them. Bunkie Clinic's one of them. But it's really sort of like where I came from in Dallas, there was one person doing this. And that's a 2 to 3 million person catchment area. And you have one surgeon that's even kind of tackling brachial plexus along with spinal cord injury and tetraplegia and spasticity. So it's something that's I think on the onus has been on surgeons, specifically either orthopedic surgeons or plastic surgeons that go into hand. I took the plastic surgery route. Doing peripheral nerve surgery is something that I was interested in right away. But then when I started seeing these patients in my last few years of training in Dallas, I was like, wow, this is just a population that is basically kind of getting ignored by a lot of upper extremity surgeons, hand surgeons, and plastic surgeons. And it's not like it's not like it's not there and it's not visible. It's because I think the challenging part of it is it is a difficult, sometimes difficult surgeries. They're hard to know where you're kind of going at. And I think the population of surgeons is also small. So I think these people that are going towards trying to treat these patients, usually try to get together and do annual meetings or every other year, every other like 6 months meetings. And there's sort of this incubator that has been sort of, in my opinion, growing. So I've been a few of these meetings already the last few years, and it's sort of catching on. And I think the ideas are being shared, and it's sort of an exciting thing to kind of be behind. So the way we sort of measure things in terms of specifically upper extremity problems, and I say upper extremity because while lower extremity I understand is obviously an issue as well, and spinal cord injury, the surgeries for those have been a little more challenging, always with, especially with spasticity, but also in paralysis. And so there are some orthopedic surgeons that can offer those things. Right now I'm trying to tackle on upper extremity because that's the base of most of my specialized training. But please understand that I understand that lower extremities are also a big part of this. And so the way we're kind of measuring this in terms of the surgical evaluation, just kind of a broad speaking, is what function you have in certain muscles. So it's this international classification system that we're utilizing for planning. And different muscles are sort of brought online the lower you get in a spinal cord level. So when you go from a very common like C5, C6, and you have maybe just a few muscles that are working in the upper extremity, and as you go down levels towards C7 and certainly C8, you get more and more muscles back in the forearm and the upper arm that are working. Why we kind of do this is because that means the more muscles you have in your forearm, the more muscles then we have to use for transfers to give you back function that you may be missing. So the more muscles you have in the forearms, for example, these ECRL, ECRB are wrist extensors. So if you've got two of them, well, then one of them could be transferred to something else and give you some function with that. So this is sort of this classification system, evaluation system, and it's all based on what muscles are working and which ones aren't. And I also show this to say that it's a bit of a complex evaluation. This is a hands-on sort of evaluation. This is a lot of sometimes you go to doctor's visits and you never shake their hand or you never get a physical exam from them these days, especially. I think it's sort of a lost art. But these evaluations with surgeons that treat these things is a very hands-on ordeal. It's a very physical exam, and you've got to be palpating certain muscles that are working, and it goes through from shoulder to fingertip. So it's a longer visit for sure than you may be used to. It's a lot of conversation and a lot of testing. And I personally, especially early on in my career, find that 2 or sometimes 3 visits to really hone in on the examination and videos and studying really help do it right, because the sort of measure 2 or 3 times and cut once is definitely very important in these sorts of surgeries. I think it's an important thing too to talk about. So in acute injury, a lot of times there's a recovery of a certain spinal level, usually by a year is usual in terms of course. So and these are just sort of what we're looking for, what you're able to do in terms of different spinal levels. The triceps is a huge, important part of your upper extremity function. This is something that you can have a wheelchair transferring independence. The triceps is a huge one. It's a little more variable in terms of what spinal level you have and how much triceps function you have, because some people may have more C6 contribution. So if you have a C6 injury, you might have no triceps. Whereas if you have a lot of C7 going to your triceps, you could even have a C7 injury, have a lot of function, but not have triceps. So triceps is a little more variable. And that's something I think is really important to focus on for transfer, because if you can push and propel yourself up out of a wheelchair and with your transfers, I think it's something that's it's hugely beneficial. And then so I just showed a slide to this is the kind of different stuff we're looking at, different spinal cord levels. And the wrist extension and the finger flexors, those are less variable than triceps. So typically, if you've got a low spinal level, CAT1, you've got a lot of intrinsic hand function, extrinsic function. You can grab, you can grasp, all those kind of important functions. So if you are having a spinal cord injury acutely, you gain a level by 6 months to a year. And the idea is that a surgery potentially could bump you up, maybe not a full level, but close. So that's the goal, is a conversation about what tendon transfers could get you up at a functional level. So that's sort of the goal. Not always possible, but it's certainly one of the goals and the realistic outcomes, I think, of some of these surgeries. Um, Obviously, you have to be ready for these types of surgeries, as you all know, going through this way more than I do. It requires rehabilitation, PMR, occupational therapy, especially with the upper extremity physical therapy. And there's a different component, whether we're doing tendon transfers or we're doing nerve transfers, which I'll touch on. But there's certainly a need to be ready to do the rehabilitation part of it, transportation, all of that, and make sure that the other medical problems are sort of kind of teed up. Having said that, like I showed before, probably 50 to 60% of people are candidates for a surgery. And I think the problem is not of whether you're a candidate or not. It's more of no one offers surgeries for your population. That's generally more of the issue that I've found. So like I said, most patients are recovering in Asia level. Not everyone, of course, but a lot. And the idea is that that kind of surgical plan stabilizes by 6 months. And so I think it's important to see people early. So I'm trying to push and work with the SRI and starting to see patients within that kind of 6 month goal, maybe even a little earlier to kind of establish like where they're heading. Because it's nice to do some of these exams in sequence as the months go on to see where you're recovering and when you start plateauing. So for a patient that has potentially an availability of doing a nerve transfer, which there may be a time limit on, it's nice to have our conversation already happening. We meet each other, all that kind of stuff happening before that kind of 6 months to a year happens. Where if everyone just waits a year before I even get a referral to me, you may have missed a window, or it's harder also to figure out where you're heading in recovery. So I think earlier is better is sort of the summary of that slide. So tendon transfers, you all may have read about. These are sort of tried and true. They've been around for several decades. And it all basically, like I talked about, is about what muscles you have and what muscles function that you would like to have. So it's a little bit independent in terms of your goals, what muscles you have, and then what we're looking for, and then whether, again, you're a candidate for tendon transfers or nerve transfers. So I just want to show a case. And by the way, some of these are intraoperative photos. So for the squeamish, I'll try to give a trigger warning. But some of these are surgical photos and images. But I wanted to show them because I think it's important. And I show these like if someone came to come see me for an evaluation, I do like to show the people that want to see it because I think it's important to understand like what you're really getting into when you go for these. And I think it's something that's hard. And if you just kind of look up images on Google, you can kind of get into scary things. So I think that this is something that's important to kind of see what's being offered and what's possible. So nerve transfers are really exciting. Those are newer than tendon transfers. And the field of nerve transfers, while the idea has been around for a while, the idea of doing nerve transfers is catching on for the spinal cord population, and certainly more distal nerve transfers have caught on even in the last decade to become more and more popular to offer patients. So a distal nerve transfer means that if you have a high injury, so like this patient got cut by glass, this is a laceration up by the elbow. If you can see my pointer there, hopefully you can. This is not an injury by the wrist where this one cut was. It's actually all the way up at her elbow. So if you have an elbow level injury to your ulnar nerve, you cannot pinch and you can't move your fingers together like this. So you can't do key pinch, you can't do this. That's all your ulnar nerve is firing into your hand. So if you have an injury at your elbow and a nerve that gets cut grows a millimeter a day, you're talking about months and months and months before it's going to reach back into your palm. And usually it never actually rounds into your hand and gets that function back. So you're never able to kind of do a key pinch again, even if you repair it at the elbow. So this has been a problem for nerve surgeons forever, because if you have an injury in your shoulder or your neck, spinal cord injury, and you're waiting for recovery, those muscles are never going to be around, and they're going to be atrophied and scarred up by the time any sort of nerve comes down to it. So the idea of distal nerve transfers is something that's exciting for sort of nerve nerds like I am, because you can get sort of live wires to the muscles and save them before they become offline and scarred and atrophied. So for this patient, she had a cut nerve. That's the nerve. It's cut in two pieces right at the elbow. she's going to have to wait probably 10 to 12 months before it gets even close to her wrist. And like I said, maybe a full year and a half before it gets into the hand. It's probably never going to work. So this is a distal nerve transfer, and that's what this looks like. It's essentially connecting two nerves in her hands. I'm borrowing one from the thumb, which is a median nerve. That's a different nerve. So it's a live wire, and I can plug it in right into the muscles that help her key pinch. So the wait time for this is now only 3 months because this nerve only has to grow a few centimeters into the muscle. And afterwards, this is her just at 4 months even. And that finger is already stronger and it's able to kind of wag as she's flexing her thumb, which is the donor nerve. So the idea of these nerve transfers is I borrowed a nerve that in her brain, when she fires, says flex the thumb. And when she does that, she's able to move the index finger stronger. And I'm kind of showing it against resistance. But you can see it firing. This is only at 4 months. So at 8, when I saw her again, she's already being able to do key pinch. She would have never had that result if she was waiting for this ulnar nerve to come in by the elbow. So this is the idea of distal nerve transfers. You're able to sort of bypass waiting and for this to recover. And now she's got function at a way quicker level. So as the enthusiasm for plastic surgeons and orthopedic surgeons that do these types of surgeries, as our enthusiasm for distal nerve transfers to come along, this has been sort of folded into spinal cord rehab patients and spinal cord injury patients. And now we can offer not only tendon transfers, which is taking one tendon and sewing it into another tendon, which is sort of the tried and true, like I showed you. And you can also combine nerve transfers, which means instead of moving a tendon, we can just borrow a nerve that's going to a good muscle. It's a good nerve, it's a good muscle, and transfer it into a muscle that needs these axons, needs these live wires to work again. So this was a patient that only, we would call International Hand Classification 2. They only could extend the wrist with one tendon. So one tendon. And then they had some triceps that is very weak. And so the first goal was to get them something to extend the wrist and potentially something to grasp. And this patient was seen pretty early on in their rehab, and I think they got surgery right around 8 or 9 months. But hopefully you can see this, and my screen's in the way, but I'll move this. So this was 9 months after his nerve surgeries. He's able to extend his fingers, and now it's a week. It hasn't really started really getting strength there. You can see his extension. So he wasn't able to extend at all. We borrowed a muscle that's called the supinator. It's actually up at C5 where all those axons go. So if you have even a C6 injury, the supinator is still working. So we can borrow that. That's the muscle that can help bend your arm up like this. We can borrow that nerve and plug it into a nerve that helps extend the fingers. So the supinator to PIN is a transfer that you do to try to get finger extension and also helps with wrist extension. And so you can see a patient that had no previous ability to open the hand is now opening the hand at 9 months after the nerve transfer. And this patient was really happy with being able to open his hand again, obviously, but was having some still really bad weakness in the triceps and it never recovered. Now we're almost 2 years after his spinal cord injury, never had any triceps function. And this is why I wanted to show this, because now we're going to combine nerve transfers as what he had with a tendon transfer. So a tendon transfer to help you extend your elbow more would be something that we call the deltoid to triceps. So your deltoid is the muscle that lives on your shoulder. It helps open your shoulder up. In this kind of motion, this is your shoulder abduction. And this is really high in your spinal cord. So if you have a C5, C6 injury, typically the deltoid's still working, meaning it's still able to be transferred. You only grab one head, so it's just the posterior head. So your deltoid still works. It's still got two heads to do the job of lifting your shoulder. And you can elongate it with some fascia, which is a connective tissue from your leg. And so that's intraoperatively, we're showing firing of the deltoid. And this is some fascia from the leg. It's used to extend the deltoid, making it longer. And then that's tied into the triceps around the elbow. So this is a patient that, and this is just 4 months after his rehab. So for these tendon transfers, you do need a bit of more rehab. It's a bit more of occupational therapy, a bit more casting and splinting, especially with this one. It's almost 6 weeks. But he's able to hold his arm above his head with that triceps function. So now his shoulder saying fire, and now his elbow is extending. So this is a mix. This is a patient that had no wrist extension, no hand opening, no a very weak triceps function. Now can do all three with this kind of combination of therapy. And I just wanted to show one more potential case to kind of show you. This is another patient. He's 5 years after injury. So there is some exciting data that's come out in the last decade that has shown that even if you're many years after potential injury and you have weakness, it doesn't necessarily mean that all those muscles are denervated, atrophied, like we talked about, withered away and scarred. Not necessarily the case. It's sometimes the brain is just not being able to talk to the muscle, and the muscle is actually still alive, and the muscle actually still has nerves. It just has no connection with the brain because it's severed at the spinal cord. And depending on where that is, if it's low enough, it still means that the body of the nerve, meaning like the where the nerve is living, is intact. It just can't reach the brain signal. So in this situation, let's say, so this patient that you just saw had some wrist extension and also some finger extension, which is great because they can actually have a decent amount of function already, and they just want to have some grasp. So they can open the wrist, they can extend the wrist. You can see that kind of opening already happening. I'll show you one more time. So finger opening straight, but they just can't bend the thumb, and they can't really bend the fingers into flexion. And so this patient had an EMG. So EMGs are helpful in these situations where you're like, is this muscle that's going to the finger flexor still working? Can we still target it? And in this patient, this is another nerve transfer. You can see that even in the OR, we use a stimulator, which is like an electrical stimulator, and they can flex the thumb and flex the fingers still in the OR. So those nerves are still working. The muscle is still working, but it just can't talk. So if you connect it with another nerve, again, this is the supinator, our friend, our trusty friend, the supinator. This is 6 months afterwards. The patient is then able to flex the thumb to the index finger. And this is 9 months after. It takes some time for these to work. It does require some patience. But you can see her start to fire. So now she's starting to fire and grasp, and that thumb's coming down. So these are muscles and nerves that were already working for 5 years, but they had no ability to actually be controlled by the brain. And now you're just transferring a nerve that can be controlled into the muscle again, thus being able to give you some cortical control. So this is a paper I'm happy to send out, Charlene. This is a paper that I think if you're kind of a person, and I've met a lot of spinal cord patients, that kind of reminds me of the type 1 diabetic population. Y'all are very literate. Y'all are very tuned, and you like to read, and you like to get into the details. Maybe the most discerning population of patients I work with. Sometimes my hand trauma patients that I'm like trying to show them the x-ray, they have no interest in it. Most spinal cord patients that I meet and work with are very inquisitive and like to read papers and stuff like that. So this is a paper I'm happy to send out. It's a very good paper. It talks about using these tendon transfer techniques and the nerve transfers kind of in combination. And this was actually in Lancet, which is a very big journal. So it's kind of cool to see a person that I've seen in several meetings get a paper that's gotten a lot of notoriety in Lancet, which is a huge medical journal, usually reserved for like big medical trials and different medications. But now it's kind of showcased, I think, a population that doesn't get a lot of articles written about them, but also surgery techniques that don't get talked a lot about. So it's kind of cool to see this, and it's a great paper. And all the training that I got at Hopkins kind of followed this algorithm. So it's similar to a discussion I would have with a patient. And then just to switch gears just a little bit, but maybe not for some who are watching this or going to watch the recording. Obviously, spasticity is kind of part and parcel with some patients with spinal cord injuries. Sometimes it's just from a stroke that can cause this, but certainly can happen in the setting of spinal cord injury as well. Spasticity is a very tough problem to fix. It's usually tried for with Botox injections, sometimes baclofen pumps, implantable pumps, what have you. There's a lot of modalities to help with this. Stretching certainly can help, therapy, casting, etc. But sometimes people have such bad spasticity, there's just no way that Botox and stretching is going to stretch out someone's arm that it's constantly contracting every single day. There's just there's not enough Botox and stretching in the world to get those patients out. I mean, they're basically doing a bicep curl 24 hours a day.
Yeah, we
And
have somebody
so,
in this room right now who's going through that really bad and trying to figure out
yeah,
the problem or the solution.
yeah. So it's a tough one. And, certainly can get better. It can kind of wax and wane. And I've seen, again, the person who's where you're dealing with this, you know more about this than I do. But I'm obviously just telling you what I've seen from talking to patients, that it gets better some days, or even months, it'll be better. And then it goes back to being worse again. It can change with the weather. It's a very interesting and unpredictable sort of pathology that I don't think we fully understand it. Well, I know we don't fully understand yet. And it's been challenging for any sort of surgical options for a long time. The patients, the people that have come up with some sort of surgical plan for these patients, it's generally people that are trying to treat spinal cord injuries, because those patients come into their office too, and they're like, "Hey, yeah, I that surgery helped this hand, but this hand's stuck in flexion and elbow flexion, and that they are looking for that." So it's sort of been innovated by surgeons that are dealing with this. One person in particular, Carolyn LaFleur, which is, if you ever researched this, she's like the big name in treating spasticity surgically. She's based out of Paris. She sort of invented a lot of the surgeries that can help patients with spasticity. But it's certainly harrowing and a humbling problem to try to fix. This patient was, I guess, C1, C2, and had incomplete. Well, it's a lot sometimes these incompletes that have this bad spasticity. And there's hasn't been a lot of breakthrough options for them. Carolyn LaCour's work she's been ongoing. I think it's about 15 years now, sequential follow-ups for patients that she's treating surgically, with a mix of loosening the tendons. So um, going in and literally lengthening flexor tendons, whether that's on your elbow or your wrist or your fingers. So she's making cuts in the tendons to get them longer. And then the other thing she sort of really pioneered is cutting a small amount of the nerves that are going to the muscles. And so the idea is you can cut a half to about 60% of the nerve that are going to the muscle, and it weakens the muscle. And what she's found is that as it recovers, the rest of the nerve recovers, that it's not causing this spasticity. This is a nerve, this is what a nerve looks like, that's going into muscle. And if you just take out a small amount of this nerve, which you may not think 50 or 6% is a lot, it sounds like a small amount. It's a decent amount of the nerve to what it sounds like. But even if you leave about 30%, it can sprout and innervate 5 to 10 times as many motor plates. So if you take out half the nerve, 60% of the nerve, what we found in studies is that there's more than enough nerve to recover into that muscle that can be just as strong again in the future. But what's happening is you're breaking this reflex arc. So what people think spasticity is that basically the spinal reflex in your body is just gone haywire. And you get this little bit of stretch, and instead of your body saying, "Hey, slow that down a little bit," it's just saying, fire this muscle as hard as you can all the time, like you're trying to, like someone was trying to rip your arm off. But instead, it's you just have a little bit of extension, and all of a sudden your flexors fire. And if you've ever, talked to anyone that has these problems, you examine them, even just a little bit of extension, and then the arm can clasp up again. And so it's this feedback arc, spinal cord reflex that's just gone haywire. The idea is if you take some of these nerves out, as they resprout, it sort of resets that reflex arc. And that's the concept behind these neurectomies. And of course, loosening the muscles themselves, loosening the tendons and making them longer, also decreases the feedback loop of this tight muscle. So if you have a stretchier muscle, stretchier tendon, and you go to extend the elbow, and it just doesn't get quite the signal back to your spinal cord to send that sort of pathologic feedback loop. So that's the hypothesis behind these kind of combining both some of the neurectomies and the tendon procedures for these patients. This is just what it looks like to take some of the tendon off the muscle. So you're literally just loosening the muscle. And then also, like I said, weakening the muscle with the neurectomies. So this was a patient who was unable to feed before and was living in a sort of flexed posture. And now you can see it's much looser in the elbow. He benefited from obviously having volitional control of the elbow. Not everyone has that. But in the patient that has volitional control, he's now able to flex without kind of just constantly being flexed. He's able to extend in a much looser position. So he had loosening of his tendons, but also weakening of the biceps and the brachialis, which are the elbow flexors. So we loosened that. We weakened the muscles a little bit, and now he's able to feed himself with that hand for the first time. So this was a case that I was a part of and saw that sort of got me really hooked when you can see a patient do this for the first time. And that was a case that sort of really interested me in this topic and kind of started me going down the rabbit hole. So this is the last one I'll show, and then I'll stop talking because you're probably ready for that by now. And but I just wanted to show this last case. So I show this case because and I show this to doctors, this presentation. So some of them don't understand that even a small improvement in flexure posture can be massive for a patient. And I don't have to tell you that, or anyone watching this video that. Of course, you could tell me about it. I can't tell you about it. But this was a patient that was very tight in flexion. And this is a common thing we find. We're not really sure why it happens, but the small finger gets sort of spared. But just index, long, and ring fingers are tight into the palm. She's actually cutting into her palm with her fingernails if she didn't clip the fingernails all the time. That's how tight her flexors were. And just the same thing I just showed you, the other patient got. So a little bit of weakening of the muscle with the neurectomies is taking that nerve away, and then also loosening the flexor tendons gets her to this. And I show this to hand surgeons sometimes in presentations because, if you are showing your all-star results to somebody, you don't necessarily be like, oh, look at this home run. She can open her fingers this much. But to this patient, it was massive. One, the hygiene issue, two, the pain. And now she can get her fingers around the controls for a wheelchair. So for this patient, even what someone would tell another surgeon, a modest result, is a huge benefit to their life. And so that's why I talked about, I think these exams and the surgeries have to be extremely tailored and individualized, because this is someone that, you would never promise to. She didn't even have volitional control over flexion until you kind of unlock some of that flexion. She can now just get around the control. So maybe not a point to touch on with y'all as this kind of thing, but for other doctors, I think it was super important to be like, this is someone that I think we should see in clinic for potentially surgery, even though she doesn't have volitional control over her hand, because getting those fingers out could be huge for her lifestyle. Anyways, so that was all I have. I'm happy to answer any questions. I really appreciate y'all's time and allowing me to talk. I'm new to town. I'm new into this building. So these are sort of a work in progress, trying to get all of this started. I ask all my patients to kind of be patient with me because we're still kind of fine tuning all of the recovery protocols and working with occupational therapy. But this is something that I'm interested in helping start here at Sutter Roseville. And I think it's just been a great place so far, and I'm really happy to be here.
Yeah, thank you so much for that. That was a lot of great information. And thanks so much for the work you're doing for our community. And little gains are huge for us. You're dead on there.
Yeah, no question.
Yeah. And I really love that you acknowledge that our paralyzed parts are still alive, because that's something that we have to fight for a lot with doctors. Like, we hear a lot of the times, well, you don't need your legs, do you? Or like, that stuff doesn't work. Like, so they have a tendency to kind of ignore it, like it's not alive and it's not necessary. So it's really refreshing to hear you say those parts are still alive. Your brain's just not connecting. And that's what we have to explain a lot. Like, no, we still want our legs. We don't want you to just chop them off. You know?
Right, right.
Yeah.
And yeah, that's been a rewarding thing to see. Yeah, because like you saying, the patients that tell me you know that they're there, they, you almost have this feeling like you're like, I don't think this is, and so then it's when you go back into the OR and you can stimulate those nerves and you see them functioning, it's like more often than not, the patient's right about that.
Yeah. Yeah. I think we definitely feel like, our paralyzed parts are still alive in some ways. And some of us, I think,
Totally.
I'm not sure, in the typical or the traditional sense, we don't feel like we used to, but I still say we can still feel in different ways. We just learn different sensations on how to feel like things are happening, and whatnot. So yeah,
Yeah, totally. That's so interesting. And I always tell my spinal cord patients, well, all my patients in general, to tell me these kind of things too, because I'm learning along with you. Um, and whoever, any surgeon, even if they've been doing this kind of stuff for 25 years, if I haven't, um, as soon as you say, like, I got it figured out, let me tell you how it is, I feel like you stop learning. And I've learned so much from my patients, especially with your population, but also, why I'm talking about this is because another thing I do is lower extremity free flaps. So if someone comes in and they've got no tissue around their heel or they've got exposed bone, I can move different muscles or skin around their body to kind of connect it with microsurgery to cover a plate or bone or heel or something like that. And I'll have patients that can tell me they can feel through muscle flaps that I put on them, even though I don't necessarily connect the nerve sometimes. And it's very easy for a lot of surgeons at meetings to be like, they can't feel that it's muscle. But they'll be like, no, like I'll close my eyes and I can tell you how many fingers you're putting on my foot. And they said the same thing to me, which is like, it might not be the feeling that you can feel on your skin, but I can feel what you're doing. They can tell me how many fingers I'm putting on their free flap. That's just muscle that shouldn't be sensate. But they're, like you said, they're learning to feel things in a way that we haven't necessarily know how to measure yet.
yeah.
Anyways, there's a lot of things that medicine hasn't figured out, and it's been um, the more I learn, the more questions I have, and I feel like the less answers. So it's very humbling, right? Because you go to like school for your whole life essentially, and you realize, I have more questions now than I think I had answers. So
Well, if there's any questions we can answer for you, I'm sure there's a lot of experience in this room and people are more than willing
yeah,
to answer questions for sure.
yeah,
Um,
I love to hear y'all and to talk with my patients about that. Like I said, I've learned a lot of this from my mentors, but I've learned more from talking with everyone.
Excellent. Um, will you put the link for the paper in the chat for us?
Oh yeah, sure. I actually have the PDF. So I don't know how some people don't have access. Like there's like institutional access to like get onto
Oh, maybe can you
Lancet,
just
but I
email
can
it?
just email you the PDF. Yeah,
Yeah, and then I can send it out to the group.
wherever wants to read it. It gets a little technical, obviously, even for me. But it's sort of like hits all the highlights, I think, of like a pretty good treatment algorithm for anyone that's interested in doing their own research before they reach out to somebody about doing surgery.
Okay, so Chelsea had sent in a few questions. She couldn't make the group today, but she was wondering, can someone with zero hand function get the surgery and expect any restoration or function back?
Yeah, that's a good question. So I showed on there, we kind of go from like shoulder down. So some patients that have, like, let's say it's a C5 and they've got no hand function, but they have elbow flexion and they don't have any elbow extension. So they elbow to flex the elbow, they have no hand function. Um, that patient, I would say, is still a candidate for surgery. So there's a surgery called the biceps to triceps. So you can take the biceps tendon and put it to the triceps, and then all of a sudden you can extend the arm again. Um, Sometimes that surgery, like I said, not only I think is important for transferring, but as y'all know better than I do, if you're able to get that arm more controlled, meaning I can now put my hand in space where I want to because I have control over my elbow, all of a sudden a hand that you say, like you said, don't tell someone their parts don't work, but like that hand may be functional for pushing things into a more functional hand. That maybe if you're an incomplete, you have more hand function on one side than the other. Does that make sense? So I think you're a candidate for surgery for the upper extremity, I think, in a wide range of spinal levels from C5 to T8 to T1 C8. And I think it depends on what donor muscles you still have too. So someone that has no quote unquote hand function still may have a bunch of wrist extensors and a pronator teres, which does this to your arm. So if you can do this to your arm and you can extend your wrist with two extensors, you may have a muscle that all of a sudden now can go into thumb function or a pinch. So what may look like no hand function, just because if you have a decent amount of wrist muscle still available, then you potentially could be a candidate for something to restore hand function. Now it's not going to be, if it's tendon transfers, they're not this sort of independently controlled, motion that you would be used to, but just being able to grasp something with some strength is huge. The answer is it depends totally. It requires exam. It requires sometimes 2 or 3 exams. And then sometimes, depending on where you want to do a surgery, because some people are like, I don't like the idea of tendon transfers, but I don't like the idea of rehabbing something for 2 months and going to a rehab facility. I already did that for years and I'm sick of doing PT or OT. Let's see if you can do this nerve transfer. I like that idea because you can just make an incision, do the nerve transfer, and then I can just wait to see if it comes back. So that's why nerve transfers are nice, because they're way less involved with OT or occupational therapy. Those patients may need an EMG to see, especially if they're far out, to kind of see what's working and what's not. So sometimes ancillary studies are nice to have if you want to go the nerve transfer route.
And then her second question was, would there be any potential loss of function due to the surgery?
Yeah, that's a huge one, right? So that's a conversation we always have to have with patients, is like, what muscle are we taking away and do I need that one? So for example, the supinator, which is this muscle, I think it's relatively expendable. It's the one that does this, but that's only expendable if you have a good biceps. So if you have your biceps supinates your arm, meaning it does this, and then your supinator supinates your arm. Those are the only 2 things that do this with your wrist. So if you don't have a biceps, because maybe you have biceps triceps transfer, you're not a candidate for that other one. So it requires a lot of very thoughtful planning to only use a muscle that you have a redundant function in. So again, if you only have one wrist extensor, well, we need to do a very careful exam. And sometimes, my mentor at Hopkins would sometimes even tell people, I'm going to look before you go to sleep, we'll anesthetize your arm with some local. And I'm going to ask you to extend your wrist. And if I can't see both tendons firing, then we're not going to do the surgery, because I'm not going to take one of your wrist extensors out. So sometimes it even requires that level of being sure. So yes, it is a risk. And it's something that based on the potential plan, we definitely have to talk about and make sure that we always have one redundant muscle doing a function before we would take it to power something else. Because the last thing I want to ever do is downgrade someone's function from a surgery.
I got a question. On my hand, it functions pretty well with the tenodesis, but every once in a while, quite frequently, my thumb will just lock up in there, and then I can't grab anything until I get it to free. And trying to stretch it sometimes helps a little bit.
Mm-hmm.
A lot of times it's just locked for half the day. Is that something that I have no clue? It's actually something that's only been happening the last couple of years. It might have always happened, but not to the extent it has the last couple of years. I'm an old injury. I'm 23 years in. So.
Oh, wow. Okay. I see. Yeah, it's hard to know exactly. Those things can be, sometimes the spasticity parts can be like just specific muscles. So sometimes people can have spasms in literally just a few muscle groups. It doesn't have to necessarily be, your whole arm or your whole wrist or your whole hand. And so there's definitely patients that have just, spasticity or contractures in just one muscle group. Sometimes it's the thumb, sometimes it's a couple of fingers, like I showed before. So that certainly could be something that's happened.
Yeah, it's usually my thumb in, and then my pointer will want to curl up too. Then
Yeah.
I can't.
So your index finger and your thumb are very weirdly connected. With a lot. If you actually just sit there and try to flex just your thumb and your index finger, it's kind of hard sometimes. If you ever get bored, you can start looking at things like that. Uh, but sometimes, like my hand, when I try to flex my index finger, my thumb tries to move a little bit. So there's some more people that have different connections in there. It's called a Lindbergh-Comstock deformity, but it's not really a deformity because everyone's got it.
Is that something in time that could just lock up and then never come back?
Usually it doesn't do that. No, I have not found that to be the case. Yeah. And then the other thing, like I tell people too, to watch, to think about too, is, you know, just because you have, so I think spinal cord injury patients, I think also nerve injury patients, that don't have spinal cord injuries, but just have nerve issues, right? So that's nerve pain, neuromas, etc. They kind of get lumped into this like, oh, you're a person with extremity pain. You have nerve pain. You have phantom limb pain. And so any problem you ever have is just like you have phantom limb pain, you have nerve pain. And it's like, well, you're still getting also trigger fingers, carpal tunnel, all the things that every other person gets on their hand or their leg, right? It's still real. It still happens. But it's so funny how it's not funny to you. It's sad, but it's a very common thing that happens that doctors will ignore the common things, right? So I've seen, so at Hopkins, and my mentor is really good, Sammy Tufaha. He works at Hopkins. He's taught me everything I know about what I'm saying right now. But he sees patients all the time that have trigger fingers, CMC arthritis, right? Thumb arthritis, carpal tunnel syndrome, and it just got ignored. And if you didn't have this nerve injury or spinal cord injury, you'd go to a hand doctor and they'd be like, oh yeah, you've got numbness and tingling over here, some pain. Let's release your carpal tunnel, right? Like every hand surgeon in the world does a million carpal tunnels every year. But it's so ignored on patients that have either spinal cord injuries, brachial plexus injuries, nerve pain, and they're like, "Oh, you're a nerve patient," but it's like, yeah, but he's got a trigger finger. So they just had a routine trigger finger where your finger or thumb gets stuck in a certain position. So we see that all the time. So I think sometimes it's easy for doctors and physicians just to be like lump everything into your big diagnosis, and you get some stuff that's ignored that's actually just the common thing that everyone gets, which are trigger fingers and carpal tunnels. And anyway, so I would just say be fastidious in making sure that you're, and no matter what happens, but you also are going to get these same health problems that the rest of the population gets. And it's so easy, I think, for some doctors to be like, oh, wait, no, they have spinal cord injury. Like that's related to their spinal cord injury. Anyways, y'all probably, again, know more about this than I do, but I'm just saying, I've seen that trend a lot with other physicians, and I get referrals sometimes, and I'm like, oh, this person just has the common hand problem that every person at this age gets.
Has the arm I was telling you about that locks into
Oh, sure.
An upward position right now, and he's only seen as a regular general doctor, and they've just been trying to all the standard stuff, the muscle
Sure.
relaxers and all that other stuff, and so he was just trying to, nothing's helping him, and he's in great pain all the time from it, and it's affecting, the way he's parenting and stuff like that, and the stuff he can do. So he was trying to find the next step.
It's in LA too, but he should look it up because there's different specialists. There are definitely some in LA I know that do the surgery.
And so what specialist specifically should he be looking for?
So I would look at so PM&R, like you said, neurologist, and you can just type in like spasticity in your area, because I think it's something that usually pops up if people are like treating it in a clinic. So like Dr. Yabaz's clinic is like if you type in his name and his information, his clinic stuff comes up. But there's definitely people in LA that could treat, and it's usually PM&R, so it's usually physical medicine and rehabilitation. That from what I've seen, some of them are neurologists, but it's someone that usually would get them started on like Botox injections and rehab, and usually kind of stretching, casting, and Botox all at the same time is like the first line thing you would want to try. But there's some really big hand centers and upper extremity centers in LA. I'm sure you could get plugged into.
Okay,
Yeah.
so maybe looking for a center that's specific to hand.
Yeah, these kind of things are usually centered in like tertiary care centers that do yeah, that would have like someone doing like brachial plexus injuries, nerve injuries, stuff like that. So I would definitely go to like a bigger hub
Okay,
to start off with. And then they would be able to plug them into all the kind of subspecialty stuff that can help with that typically.
great advice.
Because I know the one at Stanford does, they're the ones that do most of this in the Bay Area. So they have a similar program.
That's where I had mine done.
Oh, nice. Yeah.
Yeah, Amy got really good results with her.
Yeah. That's awesome. Yeah. So Stanford's great, and they've written a lot of great papers on this kind of stuff. So they're a fantastic resource.
Yeah, this is an amazing resource to have because we always have, you know, we're always trying to find solutions for each other to help each other out because, you know, the knowledge out there is so slim, you know, so it's
hard. It's very silo based, so there's like, and no one's really talking to each other very much. So it's like the PM&R people aren't really talking to the hand surgeons aren't talking to PM&R people. None of the people are talking to the physical therapists that are actually seeing you day in and day out.
Yeah.
So that's our goal kind of with the Sutter program is to try to, my goal at least, is to try to make a more integrated sort of system.
Great to hear. Because yeah, I think we can all relate to that problem.
So question, it's kind of silly. So I'm high level quad. I have no arm movement or anything like that. But I do have a little bit of, I can move my first finger, which moves my thumb a little bit too, just a tiny bit. But I mean, I always thought it was weird. But if I could move those, is there a way that something's obviously firing? So I don't know, like, would that be possible? Just even look at? I mean, I don't, even if it gives me a little bit of like arm, shoulder movement, I don't know. Like what?
Yeah, it's interesting. Because like you said, usually it's like a level thing, right? So if you're able to move index finger and then not be able to move your elbow and shoulder, definitely is not the usual pattern of things. But it can, you know, the more you look at, you know, the more you examine patients and doctor patients, you'll see like that doesn't make sense. On like, look at my diagram. I'll show you this diagram of this spine, and you don't move your index finger based on my diagram. And then you're like, hey, but look. Give me my index finger.
Yeah.
So there is definitely incomplete patterns of injury. It's not always like a straight line across your spinal cord. And so, you know, again, it's such a variability. But yeah, there are patients that have a very mixed pattern where it doesn't really follow the textbook picture that I showed you of the different spinal levels. So it's very variable. But
it's just a weird question. I was like, could I use anything? Would I be able to use a nerve or whatever's firing, like to do anything else with it? Maybe, I don't know.
Right. Yeah, it's definitely possible. But you know, it definitely doesn't follow the usual algorithm. But that's, you know, like I said, the more you learn and have experience, the more questions you have and answers. So,
but I guess it's kind of weird.
Don't let anyone tell you that you don't follow the pattern, and so you know your finger doesn't work.
Spinal cord definitely does, yeah.
Yeah, right.
No one in the spinal cord is the same, yeah. But it's the same thing.
Same
thing. I can move a few toes on the same side, but it's
interesting.
Yeah.
Interesting.
So
yeah,
I was just questioning about the nerve. Thank you.
Yeah, I wouldn't be able to explain that. Yeah, it doesn't fit my diagrams. But again, this is so. It's a humbling thing to look into and research and get more experience with because patients have such variabilities.
That be something that doctors of your specialty are able to like really look into. Is there I know that they do like the nerve testing, you know, where they go in and they shock you and they can tell you which nerves are responding and stuff. But like in Misty's case and stuff, is there more ways that you can find out what's going on?
Sometimes, yeah. I mean, like you said, the EMGs or nerve conduction studies are one way to kind of look at that, and they should be able to help with that. Sometimes they're kind of disappointing in what they're able
Yeah.
to tell you. Um, and I've been disappointed by them as much as I've been helped by them. But yeah, they sometimes could be something that could help with that for sure.
Has any of this stuff ever helped nerve pain at all? Because that's another huge issue.
It's a great question. It's a great question. So I always nerve like these are difficult problems and surgeries to do, and then there's nerve pain, which is like this sort of all-encompassing diagnosis that's super challenging to figure out exactly what's causing it. So I always tell patients, even nerve pain patients that are coming in for nerve pain, like they're I would never, so for these types of surgeries, these functional surgeries, I would never tell anyone that it could help their nerve pain. And if it does, then we got lucky, or like, let's pat ourselves in the back and not tell anyone about it because we're excited, you know? So sometimes people with spasticity that get less contractures, that helps a certain type of pain that they can't describe, but it's less painful. But I would never say, I really like to not promise anything to anyone that's I can't guarantee, or it's not like routine. So I would never sell it as a nerve pain reliever. Let's say that. Only things that I can reliably say, hey, if I put this muscle that's doing this to your thumb, it should flex. But that's where I'm gonna go. And if I loosen these tendons that are way too tight and they're firing all the time, then you should have less contracture. Now, sometimes that may help your nerve pain, but I would never promise anyone that. And like I said, if that was a good side effect, then like good for us. The ones that I can tell, so like nerve pain is not in the spinal cord population necessarily, but like neuromas, people have cuts on a nerve and then have a specific spot that hurts. I will literally inject lidocaine to deaden that area to test before we go to surgery. That's one thing that I would say, like, hey, I think this might help your pain to take this neuroma out because I numbed it up and the pain went away. But without something like that, I would never promise anyone a relief of pain because I think that's a dangerous thing to say to somebody.
Yeah.
And it's so variable because like your pain could be coming from so many different things that I have no idea about and medicine doesn't know about, to be frank.
Yeah, that's part of the big problem. It's a mystery.
Yeah. Is it your contracture? Is it the spasticity? Is it the actual spinal cord that's up top that makes it feel like it's in your hand, but it's literally, the nerve pain is actually coming from up high. So it's just such a thing that I try not to tell anything that I can help with that.
So I was surprised to hear you say that earlier is better for the surgery, or earlier is better just to get to meet you.
Yeah, I think earlier the better to meet after an acute injury. Okay. I don't think earlier is better for surgery, but it depends on what surgery. So like when I showed the supinator to whatever, sometimes you can use supinator to extend your finger. Let's say that's the case. You don't have any finger extension, but you have that muscle that can supinate, and you're looking for some more finger extension. Well, let's say your spinal cord injury was right at C6, C7, and those muscles got damaged, like the actual body of the nerve got damaged. In those patients, the clock is ticking a little bit. We're getting those nerve transfers in. Because after about a year or so, if those actual the cell bodies that go to the nerve, if those are damaged, then you only have so long before the muscle atrophies and scars away. So the case I showed you where the patient had this injury for 5 years, his cell bodies of his nerve are still around. So they were below the crush. So we got crushed at C5, C6. But all the actual bodies of the nerve are still alive. So that surgery could be done at any time. You could do it 10 years later, potentially. But if it's actually getting crushed and the body of the nerves are dead in that zone of injury, then the clock ticks a little bit because you only have so long to get new axons, new electrical cables down there before the muscle actually withers away because it doesn't have a motor nerve going to it. So it depends a little bit. And they found it's probably true that if you do these within the first year, that they probably are pretty similar. But I guess my point is you wouldn't want to wait more than a year to do some of these nerve transfers if you knew that the muscles were denervated, meaning the motor bodies were actually dead. Then you wouldn't want to necessarily meet someone at a year, have your first exam at a year, and go, the clock's ticking, and actually we're already at that time where I'd like to have these nerves already, the nerve transfer already done.
Yeah.
So I guess my point is you don't want that first meeting to be at the like last moment that you have to do a surgery. Because I like I said, these surgeries are not something that you want to just rush into. And your first exam, I've had these patients with Dr. Tufaha at Hopkins that getting preferred late. They're at like 10 or 11 months, and he gets an EMG and it looks like the motor neurons aren't working. So now he's got like 1 month to book them to a surgery if they want the nerve transfers. Now, if they want to wait and do tendon transfers, of course, that could be done at any time, and there's no rush. And I would say if that's the route you want to go, wait, because you might recover fully even after another level after about a year and a half or so. But I guess my point is establishing contact earlier is never going to be bad because it gets you in. And I would say that no matter where, if you all are going to different providers, like push to get in earlier if you're an acute patient, because it does help to establish, like people that do this for a living and like the ones you met at Stanford, they like to see patients a little bit earlier because they're going to be wanting to follow that exam and get the studies all done and know the time limit on a certain surgery.
Yeah, that's interesting because a lot of the feedback we get is just wait a year before you do anything to your body.
Anything.
Just
yeah, right.
let the spinal cord injury like settle
For
down
sure.
and settle in and see where you're at. But it makes sense with the nerves. That makes more sense.
So with the nerve transfer, potentially, and like maybe you would still wait a year, but you'd be watching it from month 9 to month 12 going, is that really changing? Are you getting any better? I've seen you once a month for 3 months and nothing's changed and your EMG looks exactly the same. It's probably not going to get better. Let's do this nerve transfer if you want to go that route at a year. And so you may still wait a year, but having all that information down already and having the relationship established, I think is important.
And then what does a recovery look like after? I know each surgery is really different, but can you
totally different
kind of like at like a estimated
ballpark? Yeah. Like, so for tendon transfers, usually, everyone's a little bit different, but usually it's a rehab process. Some of them require more immobilization than others. So sometimes it's 2, sometimes it's 4 weeks of like getting in a splint. And then sometimes, depending on what it is, you want to start moving that. So you go into a splint, you would start rehabbing depending on the nerve transfer, the tendon transfer. The one I showed you to like the triceps, those get splinted for a little bit longer because you're worried about them stretching out. So those patients have splints for about 6 to 8 weeks usually. Sometimes they get a cast for about 4 weeks in the middle of that. So it totally depends on that. But generally, tendon transfers have a period of like 8 to 10 weeks of rehab where you're seeing an occupational therapist to make sure things don't scar, that it still moves. And then after about 10 weeks or so, it's usually very healthy tendon. And you can kind of get, if you were doing a little more heavy lifting, you can get back to that. That's generally like the ballpark of all tendon surgery is like, you want to move it or it scars. So you want to get in, that would be something like an appointment needs to be done. Like before you have your surgery, you have to have an OT appointment lined up. You got to move it before it scars. You can't put too much weight on it in the first kind of 2 to 3 months. But you want to move it. And then depending on what it is, you might get immobilized for longer just to let it not scarring. But that's generally for all tendon transfers for even a person with a low nerve injury that doesn't have a spinal cord injury. And then the nerve transfers themselves are a lot less arduous in that regard because, like I said, you're not really trying to move a tendon or prevent scarring. You're kind of just doing the nerve transfer. You get a splint for 2 weeks, and then you kind of just wait. You're in a waiting game, keeping the joints, doing your usual therapy of keeping the joints loose and everything. But
that's not too bad for like a tendon transfer. Seems so invasive. Like I would assume.
Yeah.
But that's pretty impressive that you're able to rehab that quickly.
Yeah, right. And so, I would say that's most protocols, you would wait 10, 12 weeks at most with a therapist. So between that kind of range. So much, everyone. I appreciate
Yeah.
your time and attention, and hopefully that was everyone took something from that. And I always get way more from y'all than I can give to you.
Yeah, I
So
mean,
if you ever want to,
if you're ever doing any research or you have any questions,
yeah,
need a spinal cord injury community to tap into, we're here. We
Yeah.
love giving out information to help, the whole community, and help any kind of healthcare professional understand us better. That always helps
For
everything
sure.
go smoothly, for sure.
Thank
Yeah,
you
that
for
definitely. Oh yeah, of course.
Yeah,
I
thank you so
appreciate
much
y'all's
for your
time.
presentation. This was great.
Yeah,
Thank you.
of
Yeah.
course, of course.
We're really honored to have you in our
Yeah, of course.
community and really appreciative for the work that you're doing.
Of course, guys.
Yeah.
All right, well, I'll definitely send you those emails then right after this. Okay.
Okay.
All right.
Thank you.
Everyone have a great day.
You too.
Thanks so
Bye.
much. See ya.